as we turn over to Dr. Karen Tannenbaum's presentation, I'd like to introduce her and our two discussants, which we're really excited about having. Dr. Cara Tannenbaum is the founder of the Canadian Deprescribing Network and is currently Scientific Director of the Canadian Institutes of Health Research. She's also a professor of medicine and pharmacy at the University of Montreal. But a key piece is that she's really a key thought leader in this area. She's a senior investigator on many of the really seminal trials, such as Empower and Deprescribe, and we could not be more excited to hear her thoughts today. Our discussants following this will be Susan Smith, who is Professor of General Practice at the Royal College of Surgeons in Ireland and another key thought leader in the area of deprescribing, and Noel Campbell, who is on faculty at the Purdue College of Pharmacy and the Indiana University Center for Aging Research at the Regenstrief Institute. So I will turn it over to Dr. Tannenbaum, and thank you for joining us. You're muted, Cara. You'll want to unmute yourself.
Hi, can you hear me now?
Yes.
Great. Well, it's an honor and a privilege to be part of this symposium at your one-year anniversary, I understand. And what's exciting for me, of course, is to be provocative. And I'm hoping to be provocative during the talk today. And by doing that, I'm going to start off maybe by asking some questions. And the first question that I have is, why are you all here today? And I'd like you to maybe put it in the chat box, why you are here. I'm having a bit of trouble advancing the slides while people put, why are you here? Maybe just advance the slide for me. Great, so some people are starting to write why they're here. I love that. Hopefully it wasn't too much of an existential question. I do see that people are starting to put in information related to their research. So it's good to know what you expect from the day. And I'm going to ask you to please advance the slide. That's great. Answers are coming in fast and furious.
Cara, with the slides, you might try the see if those arrows on the bottom left of the slide will work.
Yeah, I'm trying to do that, and unfortunately, it's not moving. Why don't we just have Melina advance my slides like she did for you and Cynthia? Great, look at all those answers coming in. People are interested in networking, doing research, seeing how deprescribing applies to their practice. Interesting. Well, one of the reasons that I asked this question, I think I'm just going to go on with my talk, Mike, and maybe you or Melina can advance the slides when we get there. One of the reasons I asked this question, of course, is to bring us back to the main goal of the USDeN network. And one of those goals, of course, is to catalyze the expansion of the quality and quantity of deprescribing research to ultimately have impact on patients. And so when I ask you, when we look at all of what you hope to accomplish today, how well positioned are you to ultimately impact the outcomes of deprescribing research? And sometimes when I do my own research, I like to talk about self-efficacy. And self-efficacy is a concept that says, how confident are you? So on a scale of 0 to 10, 0 being not confident at all, and 10 being the most confident that you could possibly be, get ready everyone. So 0 is you're not confident at all, and 10 is the most confident that you could possibly be. How confident are you that you're able to ultimately impact the outcomes of deprescribing research? If this were a real talk and I was standing in front of you, I would ask everyone to put up your hand if you're a 0. Oh, wonderful, you're putting in your numbers. Okay, so I have to calculate the mean value here very quickly, but it does look like everyone's using the full range of numbers. I think we have a mean of 5, but we did have some rogue deprescribing researchers. I saw some 8s and 9s up there. And maybe the goal for today is to share some of the tips that I've learned about what could advance deprescribing research. Now, I'm still unable to move forward my slides for some reason. I'm wondering,
Cara,
yes?
one of us is going to take over screen sharing and start sharing your slides. I'm not sure if you're going to need to approve us doing that. Mike, do you have her slides ready to go?
Let me pull them up. Why don't you keep talking, Karen? I'll pull up your slides in just a moment.
Okay, great. So if you get the slides up, the goals for today are really to learn from what early deprescribers have contributed to the field and learn lessons from them, to maybe go outside our regular discipline and see what we could learn from other disciplines about how to impact the outcomes of deprescribing. And finally, for us to work together and maybe reimagine what the future of deprescribing research might look like. So when you think of the earliest, most pioneering deprescribing researcher that you could think of, who would it be? Let me see what names come up in the chat room here. Who, according to you, was one of the founders of deprescribing? And think outside the box. It may not have been called deprescribing back then. Exactly. So that's great to see the names come up. And I think that I agree with most of them. And if I had to pick the earliest one, at least from my perspective, it probably would have been Mark Beers. And I see that a lot of you put that name up too. So Mark Beers, many of you know, was a geriatrician who unfortunately isn't with us anymore, but I'd like to dedicate this talk to him in some ways, because Mark, maybe just click down, Mike. Mark, of course, came up with the Beers list. And does anyone know why he coined the Beers list? It was because as early as in 1988, he was working in a nursing home and was the first to observe and report cognitive side effects from sedatives, antipsychotics, and antidepressants among nursing home residents in Boston. And this Beers list, which has undergone many, many updates since then, is considered an explicit list of drugs to avoid in the elderly. Mark actually developed the list to be used in a randomized controlled trial designed to reduce high-risk drugs in nursing home patients. If you could go to the next slide, Mike. The other name that came up was, who's this, guys? This is Joe Hamlin. Many of you put his name down. And Joe, please advance the slides, Mike. Joe is a pharmacist who I communicated with. He wasn't sure if he'd be able to be with us today, but very soon after Mark developed his explicit list of criteria, Joe, like a good researcher, challenged that in a way and said, well, there's no one-size-fits-all solution to deprescribing. We can't just come up with a list. Let's think more about appropriateness. And Joe worked very hard with his colleagues on the Medication Appropriateness Index, which is a rigorous implicit tool, 10 questions that ask about the appropriateness of the medication. And this tool was used, and you could find it. It was tested in VA patients, outpatient settings, primary care settings, and inpatient hospital settings. Next slide, please. And so my question to you now is, and please answer, do you think these are useful measures for deprescribing, the Beers list and the Medication Appropriateness Index? Please say yes or no in the chat box. Okay, good. I see at least one yes. Yes, definitely. Good start. Yes, yes, yes. Okay, we agree these are useful measures for deprescribing. Okay, stop typing. Now, do all prescribers use them? Ah, not so fast. Oh boy, I see consensus. Wow, is everyone looking at the chat box? This is hysterical. Okay, so if not all prescribers use them, sometimes too much, that's funny, how will, and I'm asking the US Deprescribing Network Measures Group now, let's reflect together, how will a new measure, if we were to develop that in our deprescribing research, be more useful or widely applied? hold that thought. Next slide, please. And to the US Deprescribing Network High Priority Target Working Group, I'm going to challenge you with, are nursing home residents, do you think, still high priority targets for deprescribing research? Yes or no? Put your answers in, please. Okay, maybe my questions are too easy. Okay, next question then. Are veterans, older outpatients, and inpatients high priority targets for deprescribing research? Yes. Well, they're the same targets that we had 30 years ago. And so do you think that changing or simplifying the targets will improve the impact of deprescribing in the real world? Park that thought. Let's go to Canada. Next slide. Who recognizes this very close colleague of mine? Who is that? Yes, it's Barb. Barb, hi Barb. This is Barb Farrell. I think you're with us here, Barb. So hi, and just advance the slides, Mike. Barb has been a pioneer in developing deprescribing tools, communication methods. Click it 4 times, please, Mike. Many of you know her for her webinars on deprescribing.org, the decision aids that she's developed, the deprescribing algorithms, and even the evidence-based guidelines that she's published in many family practice journals. And so one more, I guess, invention from Canada. Thank you. Who recognizes this brochure? Yes. This is the Empower brochure. Click it twice, please, Mike. And the Empower brochure is part of a study, the Empower study that I did. Go back just for a minute. And of course, we tried to see if direct-to-consumer advertising, if you will, can lead to deprescribing. And the numbers that we got in our trials, that you needed, the number needed to treat of 4 for complete cessation of benzodiazepine or other sedative, and a number needed to treat of 3 for cessation or dose reduction. Next slide, please. So are these good tools? Answer, are these useful tools for communicating about deprescribing? You could answer if you're part of the US Deprescribing Network Communications Group, or just if you think they're useful. You could start typing into the chat box. So yes, and do they cover the range of clinical stakeholders and patients? That's a trickier one. Some people say no, some people say yes, maybe not. But do you think that changing or simplifying the communication tools will improve the impact of deprescribing in the real world? So think about that one. Next slide. And of course, I don't want to have the data harmonization group feel left out. So if we really want to get into the nitty-gritty of deprescribing, data harmonization is a lot about definitions and operationalizing methods for deprescribing. I'm just going to throw this out there. In the Empower study, we defined cessation or complete discontinuation as a lack of prescription renewal for 3 months. Does this seem like a reasonable definition for having deprescribed a medication? Yes or no? What about in the Empower study, where we defined dose reduction as at least a 25% dose reduction from baseline? Is that reasonable? All right, so my methodologists feel like maybe we could have a bit more consensus around this question, but ultimately, who here thinks that changing or simplifying these research definitions will improve the impact of deprescribing in the real world? Will tweaking our definitions truly have a transformative impact on deprescribing? Next slide, please. And so you probably see a pattern in my questions. After 30 years of research, when Mark and Joe started coming up with their tools, have we perhaps created an echo chamber which promotes incremental rather than transformative progress in the field? I recently had the privilege before COVID of listening to Barack Obama give a talk. And he said that with our social media, a lot of us who are like-minded live in the same echo chamber now. So we only hear and reflect back what we think is helpful. Next slide, please. But I would challenge you today to reflect on whether we are, in fact, just building a better mousetrap. Are we going to come up with more tools? Are we going to come up with better definitions? Are we working on the same thing? And is building a better mousetrap the wrong way to bring about transformative change? Usually a mousetrap, and when they talk about building a better mousetrap, it's do you put in, like, I don't know, a better piece of Swiss cheese, or do you make the spring a little faster or something? And some people say that building a better mousetrap actually hurts creativity. I want to have a shout out to a teacher of mine, Robin Tamlin, who probably 30 years ago, when I was taking my research methods class and learning how to write a protocol to get funded from funding agency, told us that 90% of grant submissions propose building a better mousetrap, and only 10% strive to create a brand new design. But it's those 10% that are the ones that get funded. And here's another piece of wisdom from the business world. Successful entrepreneurs focus on the problems people have, not the products. Next slide, please. And so what I think we should do next is see what we could learn from other disciplines. If our interdisciplinary echo chamber is made up of people from medicine, pharmacy, pharmacoepidemiology, and I put nursing in italics because my personal opinion is that we haven't really learned as much as we can from the nursing qualitative approach to research. If what we've been doing is working with like-minded people who amplify and agree with each other about the proposed approach, then is it time to ask what we can learn from other disciplines? Let's move into transdisciplinary disruption thinking. When was the last time you read something about linguistics or social and behavioral sciences? Who here works on a team with an economist? Are you in implementation science? Anyone on this call from political science? Well, I would argue that these disciplines have different ways of looking at the world and generating knowledge that perhaps we can learn from for deprescribing research. Next page, please. Happy to see an anthropologist here. Good. I look forward to hearing your comments. So, linguistics. Here's the next test. Get ready to type. On the right-hand side of the screen, I've listed all the words that, I've used so far in the history of deprescribing. The Beers list, the medication appropriateness index, the algorithms, the decision aids, the brochures, the randomized trials, and then in a bubble, I've put the word deprescribing. Who here can tell me a fundamental difference from a linguistics perspective between the words listed under Beers list and the word deprescribing? Go. Bob, Elizabeth, good for you. Oh yes, here it comes. Okay, we do have some linguistic experts. You're absolutely right. The word deprescribing, Mike, please go forward, is a verb. And that's interesting, isn't it? Because deprescribe being a verb, a behavior, a process that leads to the reduction of medication that may no longer be necessary or risk causing harm. Please go forward, Mike. And so if we want to deal with deprescribing research, and deprescribing is a verb and possibly a behavior, it is a behavior, then it's time to look at the social and behavioral sciences to see what they can tell us about behaviors and changing behaviors, because deprescribing really is about a change from prescribing or continuing a medication to ultimately stopping it or reducing the dose or substituting it with something safer, not necessarily another medication, I should add. Now, there's many behavioral theories, and social and behavioral sciences are way older than deprescribing science, and they seek to explain human behavior. How many of you recognize the behavioral theories that I've listed on the right? And I could have listed so many more. These are the ones that I've used in my research. So social cognitive theory, I saw someone actually mentioned eliciting cognitive dissonance that gets you to change your behavior. The trans-theoretical model, some of you may recognize, is the steps of readiness for change that has recently been challenged. I learned when I submitted a paper with my postdoc student, Philippe, and they said, oh, that one is so old, we don't want you using that one anymore. The health belief model is when someone feels a threat to their health, and maybe that sparks behavior change. theory of planned behavior, many of you know, but I'm going to focus for a moment on the CALM-B behavioral model of behavioral change. Next slide, please, Mike. And so CALM-B is the model that we actually used when we started the Canadian Deprescribing Network. And CALM-B stands for capability, opportunity, and motivation. It's a very simple model. I'm not here to debate if it's the best model, but I did want to put it up here for those of you who haven't really thought about behavioral change models. And you'll see in the slide that the CALM-B system posits that behavior occurs as an interaction between three necessary conditions. You have to have the capability, psychological or physical ability to enact a behavior, the opportunity to do it, the physical and social environment that enables the behavior, and that these combine and act on motivation, which is, pay attention to the words here, either a reflective or an automatic mechanism that activates or inhibits behavior. Now, I wish that deprescribing was automatic. I think, however, that we're still in the reflective stage. And so to be able to spark motivation, I think, is one of our biggest challenges right now in deprescribing research. Next slide, please. Like I was saying, we used the CALM-B model when we set up the Canadian Deprescribing Network, and a lot of the activities of the network's different than the US Deprescribing Research Network. You'll see that although Barb and her group focused a lot on research, the Canadian Deprescribing Network was really a knowledge translation network. And so we really worked on actions, enabling people to deprescribe, increasing knowledge, skills, and resources. It was very much a scale up and spread organization. We targeted community organizations as well as healthcare professionals and policymakers. And we held lots of workshops. I'm not here to talk about the Canadian Deprescribing Network. Please check out our website if you can, but we ultimately met with over 100 seniors organizations across the country, leaders who then took brochures and tools and gave them out in their own settings. And then we've distributed over 100,000 brochures. We just keep on sending them information pamphlets for them to distribute to people in their neighborhood or their parents or their friends. So how did we motivate these people to do it? And next slide, I think I just put a star next to motivation. How do we increase multiple stakeholders' desire to deprescribe? And I want to spend a minute with you reflecting on that. You can start putting in answers if you know how to motivate people. Go to the next slide, Mike, and if not, let's reflect on it together. And of course, I always like to start with N=1. If you were a research subject and I was trying to get you to deprescribe, what motivates you? And here I've put sort of categories that there's lots of personality tests, there's lots of systems that look at motivation. But when you look at this slide, what motivates you? Are you someone, and here the clusters kind of go together, who's very goal-oriented and competitive, and you pride yourself on being effective, and you pride yourself on looking at costs and making sure that something is cost-effective? Or are you more, and again, we're all a little bit of this, but what really motivates you? Like if given all these things, where you might be happy that you're like this or not, but what would push you to act? Or are you more thoughtful, analytical, principled, methodical, not someone who's going to jump into action and regret it? You really want to think things through and weigh the pros and cons. What about in the blue? Or are you just one of those amazing, nurturing, altruistic people who cares more about others than you do about yourself and will avoid conflict no matter what because you don't want anyone to get upset? Now, sometimes I joke, and obviously I'm generalizing, and maybe I shouldn't say this if I'm being recorded, but usually medical specialists tend to fall in the orange box. Very goal-oriented, type A. Pharmacists generally, and I'm generalizing, tend to be more analytical. I mean, they can't afford to get anything wrong. They're the ones dispensing the medication. You don't want to have a medication error. You need to be very systematic and take your time and make sure you get it right. And in blue, I like to think of my colleagues who are nurses or family practitioners who are really there listening to patients, a lot of, mental health, family concerns, really caring individuals. So And again, we all have a bit of that in all of us, but when we think about motivating people to deprescribe, will the motivations be the same? And should we always be working on the same motivation strategy if people are so different? Next slide. And so when I think about some of the work that I've been asked to contribute to around COVID, and we haven't really mentioned COVID very much here today, but some of you may know that I have other, well, anyway, I sit on a task force and we look at the science around COVID. And one of the questions that came to us from the Public Health Agency of Canada is, what can science tell us about increasing adherence to masks and testing in young people? And now pretend for a minute that I'm not talking about COVID, because I was fortunate enough to sit with a group of social and behavioral scientists, and these are what came up from the literature. It's important to acknowledge in-group variation in feelings. Did we talk about feelings at all? We talked a lot about evidence, but not feelings towards masks and testing, and tailor messaging accordingly. Empathize and validate concerns, and be ready to provide support. Number 2, by all means, highlight the personal and collective benefits, but do not overpromise. Number 3, do not use fear or shame, because it may end up eliciting resistance and negatively impact the promotion and maintenance of trust in the messenger. And if you are going to message, then appear to individual social identity and shared values. Now, if you cover up the left half of the slide, what do you think about that when I talk about motivation for deprescribing? Do any of those evidence-based suggestions ring true? Well, we thought they might. Next slide. But I don't know if these have been applied to deprescribing yet. Justin Turner, who's in the audience, postdoc, and now I should make the announcement. Justin, congratulations. Justin is going to be the new director of the Canadian Deprescribing Network starting this fall, so shout out to you. Justin investigated this when he put together a whiteboard around deprescribing. And we said, well, let's do that social identity thing. You know, maybe prescribers think that they're prescribing heroes, so they could become deprescribing heroes. And so we tried to weave in some of this theory into a theory-based whiteboard. We're currently analyzing the results, but I don't know if that's going to work because not everybody has the same motivations. So how do you design an intervention that's going to appeal to different individuals' motivations and have the same impact? That, to me, is $1 million question. Next slide, please. Now, of course, it becomes even more complex because motivations might change depending on the drug class. And this was a big surprise to me in my deprescribing research and the research that I've done with our teams. So it turns out that if you just look quickly, these are Empower brochures that we've adapted for different drug classes. And the first one is NSAIDs, and we tested that in the Deprescribe trial. And there was a 58% discontinuation of NSAIDs in the Deprescribe trial. Now, just to be clear, we didn't only give the Empower brochure, we also gave an opinion, an evidence-based pharmaceutical opinion, and it was deployed by the pharmacist. And we did a lot of things in the trial, but I'm just comparing this for you. I'm not going to go through the trial right here, but compare that to the same method that we used right next to it. We tried to deprescribe sedatives and NSAIDs in the Deprescribe trial. And here there was only, although it's still pretty high, a 43% discontinuation rate in the Deprescribe trial. And this isn't above placebo. This is just the actual rate in that group. So why would there be a difference? Justin's gone on to try to apply the theory of the Empower brochure to reducing opioids. And I will let you I'll let him tell you about his study another time, but the preliminary results suggest that we're not getting the same response that we did with the other classes. There was only an 11% discontinuation rate when we sent out the Empower brochure. We didn't have a pharmaceutical opinion in this one, to a population who were chronic opioid consumers. And then next to that, I actually have the PPI brochure that we adapted for dissemination. And what we did with this brochure is we said, okay, this is getting a little bit complicated. There's obviously different motivations. Why don't we tape conversations between family physicians or family or primary care providers and their patients, and let's see how the conversations go. And of course, when they were discussing PPIs with sedatives, it was, oh, I don't know if I could really get off it. And they kind of got stuck at the should I do it? But with PPIs, we quickly moved to the how can I do it and what will I take instead, which suggests to me that each medication class almost has its own personality. Next slide, please. And so this brings us to economics. I promised you I would bring in a lot of different disciplines. And most of you have probably heard of the theories Thinking Fast, Thinking Slow by Daniel Kahneman. And these are dual cognitive processes that guide thinking and behavior. We have our fast thinking, automatic, intuitive. Sometimes I call it emotional, but it's more intuitive, and slow, effortful, and analytical. How do we apply this kind of understanding of cognitive processes to deprescribing research? Next slide, please. Some people have already started to doing it. In the field of implementation science, I was pleased to see the paper, How the Dual Process Model of Human Cognition Can Inform De-Implementation Efforts. And so this is getting more complex than making a list of drugs to avoid, because it really asks in implementation science, well, what works for whom, in which context, and why? And part of me thinks that where we need to get stronger in our research methods is in the research methods around implementation science. Next slide. And what I've learned from implementation science is that you may have on the left the most innovative and effective intervention possible. Take, I'll mention, the Empower brochure. So let's say the Empower brochure on a scale of 0 to 10 is, I don't know, it's not, but I wish it was an 8. But then nobody used it. There was no buy-in. They didn't download it. They didn't send it out. So buy-in was 1. We might only have socially meaningful change of 80%. Okay, that's high. That was a bad example. But if you have, or let's say buy-in was 0, then you would have socially meaningful change of 0. There, that's better. But if you have an innovative and effective intervention that maybe isn't that effective, but everyone uses it, then you'll enact higher socially meaningful change. And so the concept of buy-in is one that we don't talk about as much as we talk about, well, what's effective, what's the intervention, what's the methods. And so on the next slide, I just want to talk to you a little bit about getting buy-in for implementation. And this, again, was a very humbling lesson for me. We took the Empower brochure, and we've been collaborating with Indigenous communities in Canada. And I said, how can we make this look more Indigenous? Should we change the colors? Should we maybe put different pictures on it? And what we learned from First Nations is, well, we don't even think in terms of brochures. We think in terms of stories. And in our culture, we tell stories, and Coyote is the most renowned storyteller. And if you really want to get these messages out, then we'd be willing to work with you to maybe come up with a story about Coyote's food medicines. And there's a way of telling these stories that makes a lot of sense to people. And I think you'll have much more impact. So, wow, for those of you who are curious, please go read this brochure. It's absolutely amazing. It's about Coyote who wants to make his food stronger, so he tries to learn from the other animals what they eat so that he could eat it too, in brackets, the medicines, and he gets sick from eating everyone else's food because it wasn't the right thing for him at the right time, in the right place, etc. So, wow, that's what I call getting buy-in through an intersectional lens. And for those of you who aren't familiar with the term intersectional, next slide, it really means bringing together different voices from different situations in life. So people with lived experience, people whose voices we don't usually heard or give opportunities to speak. And here, of course, I'm going to mention gender, racism, age, it matters what occupation you are. What about the experience you have of being a VA? What's your ability? What's your cultural background? Are you a newcomer to North America? What language do you speak? Do you live in an urban or rural area? And this reflection worksheet that was developed by Canadian researchers is about asking yourself questions. Where am I situated? How do I see the world? Is it different than the way the people who I'm trying to help see the world? And if it is, should they be part of the decision-making processes in the research right from the beginning all the way until appraising the evidence and identifying the problems? Next slide, please. And so I'm challenging you that if we really want buy-in and we really want to have impact, then what we need to do is also influence. We need to influence people's motivations. We need to influence people's behaviors. And please forgive me for talking about political science. As I mentioned, I've been working with governments a bit, but I have learned a ton from my government colleagues. They really know that the science of influencing people. And influence is about relationships. It's not about reading a brochure. It's not about, grading the level of evidence. It's about who do you have a trusting relationship with? Who do you trust? And it's that trust sometimes that pushes you to act. And so how and with whom can we build trusting relationships in the field of deprescribing research? And what's the secret to making these partnerships win-win? I don't think it's just asking someone to be on a committee. It's, as I've learned from my Indigenous colleagues and in politics now, it's truly about building and maintaining relationships. Next slide. We have an action plan. You have an action plan. The Loan Institute came up with a brilliant action plan, if you haven't already seen it, to reduce medication overload in the US. But who's going to implement it? And how can you build critical relationships to influence, work with, and evaluate implementation of the action plan? Next slide. And so as I come to the end of this talk, which hopefully will spark some thinking, I hope you're all thinking. People haven't been typing in as much, so hopefully you're all thinking. I'm going to invite you to reflect with me what reimagining deprescribing research might look like. And in science, I worry that we're still stuck in the 20th century science approach to deprescribing, which is a very reductionist approach. 21st century science embraces complexity. And if we're going to embrace complexity, then we're going to need to move to transdisciplinary team science. We're going to have to think about being theory-driven. We'll have to focus on different motivations for different stakeholders to deprescribe and be inclusive of all stakeholder voices. Be sensitive to culture and power imbalances in the way decisions are made, and build trusting, ongoing relationships with important change agents. Next slide, please. That might seem daunting to you. That might seem too complex. You might think that I'm being unreasonable to ask you to rethink the way we're doing deprescribing research, but I say lean in, embrace it, be unreasonable. And if you'll allow me to quote George Bernard Shaw, who said, "The reasonable man," and here I'm being unreasonable and I'm putting woman, and I could even put gender diverse person, adapts themselves to the world. The unreasonable one persists in trying to adapt the world to themselves. Therefore, if we want progress, all progress, including changing the words in this slide, depends on being unreasonable. Last slide. And so I give you permission to be unreasonable as we think about the future of deprescribing research. Not only will patients thank you, but you will make a difference on the ultimate impact of deprescribing research. Thank you, and we'll go to the next slide, and I'm really interested in starting the discussion.
Thank you so much, Cara. That was fascinating and very thought-provoking. As the questions roll in, and I've seen a couple I've written down, but I'm sure there'll be more, I'm going to first give Noel and Susan a chance to comment or ask a question. Noel, do you want to lead us off?
Yeah, that'd be great. Hi, Cara. Hi, everyone. Appreciate the opportunity to comment here. I was challenged with two things, Cara. First, is keeping up with not only your content, but the chat. So we've got a really lively group. But I was challenged also with the enthusiasm that you raised for a lot of different opportunities to study deprescribing research from different perspectives. And I want to ask, or maybe kick off some of the question period with, based on your experience, as I'm like-minded, right? So I believe that behavioral economics and behavioral psychology certainly has a role, and I see a number of human factors engineers participating today too that would agree. And we've recently experimented with some of that, results under review. And it's challenging, right? So it's challenging. I'm a pharmacist by training. I'm not good at it, right? So I admit that. And I'm curious from your perspective, we think that some of these behavioral principles can be applied to patients, providers, but do you think we're more likely to be successful? If you could make a guess now, maybe on your scale of 0 to 10, are we more likely to be successful influencing behavior or motivating that stakeholder group, that limited stakeholder group, the providers, the patients, maybe the pharmacists? Or are we more likely to be successful at motivating policymakers to really force us to change our behavior?
Well, Noel, we know each other well, so I think you could probably predict my answer, which is all of the above. I did some research early on in my career in change in long-term care institutions. Talk about a complex place where people are suffering right now. It's been tragic what's happening with COVID, but I looked at it from an organizational perspective, and we evaluated top-down. So what you're describing as policymaker top-down approaches versus, so the head of a long-term care institution, if they just say, we're not going to prescribe this anymore, then does that happen? Or the prescriber, but also bottom up. But who actually gives pills? Who takes care of the patients? Do the care providers and the nurses, should they be having a say in this? And we found that there's, consequences to doing both. So governments, when I think about Medicare Part D, when they said they weren't going to cover benzodiazepines in long-term care institutions, sure, they stopped. They stopped, what was it? I think the rate of benzodiazepine use went from 27% to 17% in a month. So it dropped by a lot, but there was substitution with other medication classes. And so every policy has a loophole. On the other hand, if you could change culture, if you can make people understand that no matter what medication you give for sleep, it's going to put your brain to sleep and make you at higher risk of falling and affecting your memory, then maybe we could work on the alternatives. I didn't talk about alternatives today. I think we're doing a really bad job at giving alternatives, non-pharmacologic alternatives. And so my answer to you is I think it has to be a multi-pronged approach. This is a wicked problem. That's what they call it in business, a wicked problem, where you really need to intervene on multiple levels from different angles, and it needs to be done simultaneously. So that's exciting if you're worried about getting bored. A little daunting for a pharmacist, Noel. I think you probably fall in that thoughtful, methodical, analytical box, but then get yourself a transdisciplinary team to work with.
Thanks, Cara.
That's great, Cara. And the questions are starting to roll in, but I'm going to let Susan, if you have a comment or question, join in.
Thank you very much. And thanks so much for including me in this. Cara, that was a fantastic talk. I really enjoyed it. I loved the multidisciplinary feel for it. You're clearly very experienced and knowledgeable. And it's a pleasure always to listen to somebody who's really on top of their game and knows all about their field. So I'm going to my comment, I suppose, which I find, I suppose as a clinician, as a family practitioner, working in an urban deprived area, one of the things that's part of the COM-B model is this idea of capacity. And one of my big concerns, both for my fellow clinicians, is that they're working in systems that limit their capacity to engage in this. And for my patients, their poverty limits their capacity to think beyond, like, how am I going to make it to the end of the week? And I just wonder, with your experience, what kind of interventions, or approaches can we take for those really wicked problems?
Yeah. So of course, the answer is change the system and increase the benefit package for to raise the poverty level. But if you can't do that tomorrow, I think that our research, so I don't know if poverty is associated with educational level where you work. So I can't comment on socioeconomic status per se. There's certainly been research showing that socioeconomic status is associated with a higher use of, say, benzodiazepines. But sometimes education is also associated. And interestingly, when we did some of our research, we thought that the most highly educated patients, let me focus on patients, would be the quickest to adopt deprescribing. And in fact, what we found is that it was those who had never been exposed to the concept that a medication might, have harms that you're not aware of as you get older, who saw this for the first time and hadn't, I guess, decided on their own in whatever cognitive processes that they weren't going to do this. So I think my answer to you in that setting would be personal empowerment and social identity. And they care about their community. They care about their loved ones. I love to say to people, it's just, I'm really worried for you. I wouldn't want you to fall and break your leg because I know that you help take care of your grandchild while your daughter works, and we would not want that to happen for you. Now, I don't know if that's manipulative or whatever, but it's true. So that social identity, and it's maybe some of the research that we're discussing today with COVID. How do you empower communities who are most at risk because of those characteristics to be more protected against COVID? And it's about protecting the community, protecting those they love. But I don't know. You would have to try that. Look at theories, look at some of the things we're doing around COVID, and just don't give up. Keep on pushing. You may have a mayor who decides to make this a campaign. Justin got all of Newfoundland to put ads on school buses about this. You never know what'll happen. So be creative and ask people what they think, maybe. Why don't you ask your patients what they think? That's probably what I should have said in the first place. Okay, sorry, talking too loud.
Very much.
That's great. And we do have a bunch of questions from the audience. Cara, we obviously folks would love to hear from you, but Noel and Susan, please feel to chime in so it's more of a conversation. So one question is earlier you talked about what a new measure might be that would actually be useful for deprescribing. And folks would love to know, what would you think about that a new measure should include in order to be useful if we were to sort of be trying to envision the next generation of measures?
Well, I think the working group has a lot of work to do on that. I think for me, it might be a measure of what you can do instead. I said that I didn't talk so much about alternates, but deprescribing is essentially saying no. And anyone who has children knows that if you say no to them, I don't know if it works or not, but you're supposed to give an alternative or have them choose between different things. And I feel, we talk about shared decision-making, and there's a lot of shared decision-making tools. I think they're quite complex. So if I had to imagine something totally new, it would be maybe that someone's inclination for moving towards something less dangerous, or maybe an understanding of what the alternatives could be. Because we say, are you willing to deprescribe, but are you willing to do something else? I'm not sure that we focus on those alternatives a lot. That won't help the epidemiologist, but I did sort of focus on behavioral here. And of course, measures encompass so much. I didn't even ask you, do you mean an outcome measure? Do you mean sort of a predictive measure? Do you mean, cognitive process measure? So yeah, I'm gonna leave that to the next generation of deprescribing researchers. Go for it.
I think it's a great point, and it really speaks to what you said, that we didn't even to what degree do non-pharmacologic alternatives really kind of need to be on the table and part of the conversation about deprescribing. It's not in the verb and the definition that we have, and yet it does seem like such a vital piece of the puzzle. That actually, Noel or Susan, please just chime in if you want to chime in, but that relates to another question that someone asked earlier, which is whether the term deprescribing is also limited in another way, and should we figure out a way that it also is inclusive of not starting things that we shouldn't be starting, and should that be part of our definition?
So yes, I think that initiating potentially inappropriate medications is as important, if not more important, than deprescribing medications that people are already taking. I do think that you need a different theoretical model to approach that. I would expect that the barriers and enablers would be different. And what they do have in common, of course, is I liked your point, Cynthia. You know, of course, I don't think we should be initiating inappropriate medications, but what can you do instead? Because people aren't just medication hungry. They really don't want to spend all their money on medications and have side effects. There is something that's bothering them that's pushing either them or the prescribers to take these pills. And so when I said, let's not talk so much about the product, but the problem, what are these problems that we're not offering better solutions to? And that should also be in the definition. So I'm not saying no, sure, throw it in, absolutely, but then don't conflate two things that probably require different interventions too.
Interesting. Susan or Noel, there's lots of questions in the chat, but while I'm picking one, if either of you want to comment, feel free.
Well, I mean, we did try in a trial that we ran a few years ago that was led by my colleague Barbara Klein we structured the whole concept around offering non-pharmacological alternatives. But I was very struck by Cara's slide with that multiplier of buy-in. Interestingly, they were elderly patients who all had at least one PIP or potentially inappropriate prescription, and they trusted their GPs. They weren't interested in changing. They said no thanks to the leaflets. You know, it was just, it just wasn't enough. There needed to be something more. We needed to talk to them more, as we did afterwards, obviously, and designing it, but we just didn't get it. And there's some kind of holy grail in this where you can link, where there's a moment, Cara, your idea earlier of that, you know, where somebody sees what's in it for them really and understands the benefit to them as a whole person, not just in this moment in a consultation with a clinician.
Yeah, that's a good point. And I'm going to build on what you said about they just trusted the prescriber. I think trust has a lot to do with it. If you get an intervention as part of a research project, I don't know how much you trust the research project. So this idea of the trusted messenger, again, not only for the COVID messaging, but also for deprescribing is maybe something that we could do more research on. Of course, that brings us back to the prescriber and how do you change the prescriber behaviors, but then who does the prescriber trust? There was an article in JAMA, was it this past weekend? I didn't include it in my talk because I already sent in my slides, but look it up. I think it was by William Schrank, and he talked about the 3 E's that you need: evidence, eminence, being a key opinion leader, and economics to really drive de-implementation. Science, I think it's a little bit more complicated than that, but this idea of eminence and who you trust, I think is really coming out in what you say too.
That leads into, there's a couple of questions in here about what you think the role of cost effectiveness research is in thinking about implementation in this area. And I don't know if you would be able to comment on that. If we need more economic analyses, or if cost effectiveness research to really be driving change.
So cost effectiveness research is critical for driving change among policymakers. So both Noel and Susan talked about systems and policymakers. And of course, money is a big driver of system change. Now, it's tricky because it's obviously, you know, cheaper to give a 5-cent benzodiazepine than to pay a psychologist to sit with someone and do cognitive behavioral therapy, unless you take into account the indirect side effects, which are the falls and fractures from giving benzodiazepines. So I think we need a few good studies, and I think they just need to go in a briefing note. And a briefing note, for those of you who don't know, is sort of the equivalent of an abstract for policymakers. It's a 2-pager that basically says what the financial, social, professional implications of any decision made by government would be. And yes, you need a paragraph on the finances of it. So yes, we should be doing economic research, but I don't think we should go too far down that rabbit hole. Get a few good studies. Put your, I think in Canada, we talk about how it costs $1.4 billion in Canada because of all the falls and fractures from all these pills. And we're trying to get through a, pharmacare plan, but it's not that easy. But that's where I think it's important to actually, or maybe in the States for the insurers. We don't have insurers here. Maybe you could use insurers as partners, but it sounds like the wrong reasons. But hey, as long as you accomplish the goal, go for it.
Yeah, I know someone commented in Medicare, co-pays are $20 per visit for psychiatry or psychotherapy much more than drug copays in the US. So it's certainly an important lever, I think. While we're just about ready to go into the breakout rooms, I'm going to ask one more question, which a couple people commented on, which is that given that trust is so important, and people's time for visits and the sort of the thought of building a relationship with their provider is one of those things that take time, that many of the barriers to deprescribing may be the same barriers that we have, at least in our health system, for people really able to be building those trusting relationships. And so I'll let the three of you comment on that if you wish, and then we're going to wrap up and roll over into the breakout groups.
I'm going to punt this to Susan and Noel because family practice and working as a pharmacist. What do you guys think?
Well, I couldn't agree more that it is absolutely central to, you know, and there's so much evidence around continuity of care. I mean, I suppose one of the things, Cara, you brought in all this multidisciplinary research, but even within clinical research in primary care and in specialties, we have all different strands of research, which really is about the same thing. So there's a whole load of stuff on multimorbidity, whole load of stuff targeting potentially inappropriate prescribing, polypharmacy, and then deprescribing. And now I think we're about to start into prescribing cascades is the next kind of thing that seems to be coming. And we also need to integrate those things, because for a patient, they're all happening simultaneously. And for the provider, the difficulty of looking into a prescription with 15 or 20 items on it and just wondering, like, where do I go from here? Trusting themselves, and also, you know, that trust the patient has in them. They don't want to let them down.
No?
Yeah, thanks. I think it's an interesting opportunity. I think it's complex. I think there's an opportunity to personalize each of us. So there's a lot of heterogeneity in approaches. And I think there's a group out there learning about personas and also developing these menu list of opportunities and matching personas to those interventions. And I think I don't want to be, if I probably align my comments and my response a little bit more to the question, you know, I think I don't want to be too redundant, but I think behavioral science offers some answers there too. If you're creating a relationship, you might start a conversation in one visit, but 6 visits later, you get what you want done. Or you make the attempt or create the change that you think it takes, but it might take some time. It takes multiple hands. I think there are ways that engineering, human factors engineering, can improve our efficiency at addressing those problems. So we can employ the resources that are just sitting out there that are unused, but also better defining the types of people, the heterogeneity that exists around the problem that can help us get there quicker.
Yeah, those are great thoughts. And I certainly don't have an answer. And I know it's daunting to be talking about feelings and trust. You know, when maybe people thought I would just talk about analyzing a data set, that seems a lot more kind of tangible. But people connect through vulnerability. And I think more than ever, as we study the lessons that we're learning from COVID, we probably underestimate the role of feelings and connection in influencing and driving behaviors. So I'll leave it there because I'm getting out of my comfort zone, although they do say that you have to step out of your comfort zone to grow and change. So if you're feeling comfortable with the research that you're doing and you want to take it to the next level, then I guess my last word is to challenge everyone to step out of their comfort zone so that we can really grow and transform deprescribing research into areas that one day people will look back and say, oh yeah, at the beginning of the 21st century, they started focusing on behavior and feelings, and hopefully that it'll all be fixed. So, okay, thank you very much. On to the breakout session.
We're assigning the last couple people to breakout groups. So I'm just gonna read a comment from one of our participants, Janice Toft, who noted that empowerment of patients has a lot to unpack. Does the patient have access to affordable transportation, housing, and healthy, affordable food? If someone's missing any of these above, how can they really be empowered? And I think we've touched on some of those things already, but I just think it is a really important reminder about how this is such a piece of a much larger puzzle. So I don't know if there's any last reflection on that, and then we should be, I'm going to turn things over to the group to give instructions in just a second.
Yeah, I think, thanks for that comment, Janice. And you know, I'm going to pivot with it. And I'm going to say, think of how much resilience those people have. And I can't pretend to understand their lives and how they, some of them are probably in better spirits than I am when I wake up in the morning. And I just feel that we have so much to learn from them. And I would challenge you that those people absolutely could feel empowered about taking care of their loved ones, about taking care of their health, you know, about finding solutions together. I think that there is so much wisdom and lived experience that us academics and pedagogical nuts, you know, maybe don't appreciate. It's those silent life competencies. And I would posit that maybe they have just as many answers as we have. So let's enter with humility into the future of deprescribing research. Again, like Susan said, I wish I could change the system. I wish that I could have better, you know, social support for these individuals. But as individuals, they have as much to offer probably as we do in terms of solution finding. So I'll end on that note of positivity. Maybe it's a little bit too positive, but hey, we're trying to be inspiring and game-changing today. So there you go, Cynthia.
This was so great. We so appreciate all three of you, your time and your interest in all of the great questions from the group.